So my biggest thing that I'm involved in right now is ARGUS 2 retinal prosthesis. So we're one of the 13 sites in the country that do that. So that's kind of something that I'm very involved at the moment. And I'm doing other research projects, clinical research. But ARGUS is probably the highlight of my work. ARGUS 2 retinal prosthesis is a retinal prosthesis that's been approved for retinitis pigmentosa, only for patients whose vision has deteriorated so much that they have bare light perception. There's actually studies in UK looking at use of ARGUS retinal prosthesis for AMD, for age-related macular degeneration, but that's still in research stages. So as of now, the only patients we're allowed to implant those devices are patients with retinitis pigmentosa. You know, it's pretty rewarding because it's patients who used to have normal vision. You know, they're born with normal vision, and as time goes on, and not all of them, but some of them slowly progress and lose that ability to do things they like to do. They're not able to work, they can't see their family members, and ARGUS 2 retinal prosthesis, it doesn't give them the vision back, but it doesn't restore the vision, but it gives them new vision. It's pretty rare. It's pretty rare to begin with, and then people who actually qualify for ARGUS, it's even fewer. We've been doing it at Kolai for about a year. Our first patient was July of last year, and we have done 6 cases. And we are, you know, at that rate, we are one of the busiest sites in the country. So in a lot of places, it's 1 or 2 patients, because you know, you also want to make sure that you select the right patient. So not only the diagnosis and the vision, but also their motivation to learn, because a lot of these patients are older, and if they're not going to embrace that new technology and spend time training how to use it, it's not going to be of benefit to them. There's a couple components to it, and so the patient actually wears glasses, and the glasses have a camera right in the center, and the camera captures the scene. So that's how they see. The camera captures the scene, and that information gets sent to something called video processing unit that they wear on their waist. So as the name suggests, it processes that video input and then sends it back to the glasses. And on the glasses, there's an antenna on the outside, on the glasses, that communicates with the antenna that we implant outside the eye, under the conjunctiva. And then the information is sent to the electrode array. There's 60 electrodes that we implant right in the macula. And those electrode arrays get stimulated, and then the information goes through the optic nerve to the brain. And it happens pretty, you know, it's a long path, but it happens almost instantaneously. It's not the vision like you and I think of vision. What they see flashes of light. And so the way the process is, you know, it's a very rigorous selection process, first of all. Then we have to do surgery, and the surgery is pretty time consuming. You know, it's the longest surgery I do out of all the surgeries. Depending on what you have to do, it can take anywhere from 3 to 5 hours. After that, the eye heals, and we turn the device on. And that's when, for the first time, the patient starts seeing flashes. But they don't know what those flashes mean. And then, after that, they undergo this very involved rehabilitation process. We partner with our sight center locally in Cleveland, and they actually learn how to interpret those signals, how to interpret those flashes, so they know by, you know, what the flashes look like. Oh, I'm looking at a person, or I'm looking at a table. And it's easier, they don't see colors, it's based on contrast. So the flashes, you know, are brighter or less bright based on the contrast. So, you know, they might have easier time seeing a white plate on a dark tablecloth, and that would present as flashes. And so it's very hard to explain to patients before you implant what their vision is going to be like, because they don't see objects, they don't see shapes, they see these flashes. In the original study that got ARGUS approved, there was some complications that were seen after the surgery, and actually there's been modifications in surgical technique to minimize those complications, and we haven't seen any of those complications. No eyes have been lost to the surgery as far as I know, and there's, now we're looking at the data, not that the device has been approved, we're all collaborating because all the investigators have so few cases ultimately, so we're all collaborating and looking together with the company, the second sight company, to look at the outcomes. So everything that's outside the eye is replaceable. We actually tell the patients, because they have the same concern and they're scared to use it because they're like, I'm going to break something. There's so much things on me, so many things on me. And we had a patient who, our best user, and he broke his glasses. And we're like, good, it means you're using it. We got him new ones. That's not a problem. In terms of, everything that's implanted on the eye, it's inside the eye, and now there's data several years after the first ARGUS, and we only know information from when the first ARGUS was implanted to now, which is not 50 years of experience, but there's no toxicity or anything like that that has been seen. There's actually a patient who is here at ASRS, I've heard, who has ARGUS 1 in one eye and ARGUS 2 in the other eye. There's gene therapy, but the patients who qualify for ARGUS, the disease is so advanced they actually wouldn't qualify for the other interventions that are currently available. Better than 20 years ago when there was just nothing.